We're live.
Thank you so much. So good afternoon and welcome to this joint briefing for the Senate Finance Committee and the House Health and Government Operations Committee. This is a virtual committee briefing, so I ask for your patience if we encounter any technical streaming issues, which sometimes happens. This briefing is being streamed on the General Assembly YouTube channel. Members will be muted throughout this briefing. If you have a question after the presentation, please use the raise hand function, which is located either underneath the participant list on the right side of your screen or under the reactions bar at the bottom of your screen. After your name is called, please unmute yourself. Remember, even though we're meeting on Zoom, please refer to our usual HGO committee rules of one question and one answer from the panel. Also, please keep your questions brief. Today's briefing will include presentations on the impact of HR 1. We will hear from the Department of Human Services on the impact on SNAP benefits and from the Department of Health on Medicaid benefits and administration. Before we start with Webster Yee from the Department of Human Services, I would like my partner in crime across the street to go ahead and say a few words. Chair Bidel.
Thank you, Madam Chair. Just thank you for getting this scheduled. I have a few senators on. Thank you, Senator Jackson, Lamb, and Guile. They're the ones that I see, and council. We're looking forward to hearing about HR 1. I think I hear something new, not positive, but something new about HR 1 every day. So I'm looking forward to the briefing, and thank you for getting it scheduled.
And thank you for being my partner, truly. And I want to thank the HGO committee for being here. I am so grateful that all of you, HGO and Finance, make the time to be here, because I know this is supposed to be a part-time job, and it isn't. People do not know how hard we all work and the hours that we put with these hearings. So I have my vice chair as well here, Vice Chair Carlos, and welcome. And I want to thank my wonderful staff and Senate staff for putting this, it takes a lot of work to actually get us here. So I want to thank them for doing that. So let's get started with Mr. Yee, Webster Yee from the Department of Human Services. Webster, it's nice to see you back. So welcome, and you can get started.
Absolutely. Thank you, Madam Chair, both Madam Chairs, for an invitation. My name is Webster Yee. I serve as the Chief of Staff for the Maryland Department of Human Services. I'm joined by a number of my colleagues, including specifically Larry Handrahan, our Assistant Secretary for Programs, as well as Heather Zanoni, who is our Assistant Secretary for Policy and Data, as well as colleagues from the Maryland Department of Health. And I think, let's see, I see on my screen Deputy Secretary Perry Briskin for her part on the Medicaid side, as well as Pat McLaughlin, our Executive Director of Maryland Benefits, and Michelle Eberly, Director of the Maryland Health Benefit Exchange. If I could trouble the committee staff to present the slides or share the screen, I would be helpful. If not, I'll be happy to just start talking.
You can start talking while they set it up.
Absolutely.
Thank you.
I think the most important part about HR 1, and what I'll do is Larry and I will take this in two sections, is I'll give an overview along with the recent impact of the federal government shutdown, as well as Larry will then take over and talk about the specific implementation of HR 1. With the Maryland Department of Human Services and SNAP, HR 1 is considered to have taken effect on July 4th, 2025. And then the United States Department of Agriculture sent us a nice little note saying that, according to them, the 120-day period to implement HR 1, the clock started ticking on November 1st, 2025. So it's now in effect, according to our federal friends. One particular note that Larry will highlight later is literally with about 6 hours to go on October 31st, we got a note from the USDA saying, hey, here's the guidance for implementing HR 1 with respect to new Americans. And that has been a struggle. I can also report to the committees that this is a matter that we have worked very closely with the Maryland Office of the Attorney General Brown and his team. There has been a long set of multi-state litigation, of which Maryland has been a leader and party to, that informs a lot of the work that we've done, that we will do, and will continue to do. And so a lot of the information that we're going to give you is current as of today. And we'll go from there. SNAP is vital, and so if I could just beg you to go to the next slide, Mr. or Madam Committee Staffer, thank you. SNAP, as we've seen over the past month, is vital to America's social safety net. We put up some statistics, but you can see it on your screen. It serves over 680,000 Marylanders, and we issue approximately $1.6 billion in federal funding to Marylanders each year. That amounts to $180 per month per person. Prior to HR 1, SNAP benefits were 100% federally funded, and administrative costs were split 50-50 between the federal government and the states. That's now changed. Next slide, please. Perhaps most importantly to the committees, this chart illustrates vividly the impact of the customers that we serve across Maryland. We've broken it down by children and adults. As you can see, 270,000 children are impacted every time there is a change to SNAP. And I'll just give you guys a few moments to take a look. And then next slide, please. And one more slide, please. So with the recent federal shutdown, which ended in mid-November, we had to take extraordinary actions. The governor declared a state of emergency. We worked very tightly with the Department of Budget and Management, Secretary Weissman, and others to ensure that through the governor's emergency order, Marylanders were not left in the dark, were not left hungry. And so what Maryland did in November, we were able to use remaining funds carried over from the previous federal fiscal year to issue SNAP benefits in October. But beginning November 1st, and in Maryland, we issue SNAP benefits from November 4th, or the 4th of each month, through the 24th of each month. And so Marylanders from November 4th until about November 17th were greatly impacted by the federal government shutdown because there were no funds. We used state funds to issue partial benefits. And on November 18th, we were able to issue 100% federally funded SNAP benefits to customers. That amounted to about 72.8, almost $73 million in benefits then. And then starting November 18th through the end of the month, we were able to ensure that they received their normal SNAP allowances. And so happy to provide more information, but we were pleased that we were able to work together as Team Maryland with the federal delegation, with the state, all the state agencies to ensure that Marylanders were not as harmed by the federal government shutdown. Next slide, please. In addition, as part of this, Governor Moore announced a $10 million emergency grant to support Maryland's food banks and community food pantries. And the breakdown of the $10 million was $5.5 million to the food bank, $3.5 million to the Capital Area Food Bank, which serves Prince George's and Montgomery counties, and then another $1 million to augment what the General Assembly has existing funded through the Maryland Emergency Food Program. And so together, all of these buckets of funding, we were able to push out funds to every community food pantry that applied to the Maryland Emergency Food Bank, Maryland Emergency Food Program, as well as support the two food banks partners to get funds and food out to community food pantries and to Marylanders in the week or so before November, as well as impacted federal workers. In addition, a couple local jurisdictions were also announced county-funded emergency food assistance. Next slide, please. In addition, Governor Moore announced an additional $10 million to continue Maryland Energy Assistance Program benefits to customers. And what happened was with the federal government shutdown, the funds that we would have received, which are approximately $90-odd million, did not materialize for November, right when the weather got a lot colder. and our applications increased. I'm happy to report that literally a day or two ago, we received the federal award notice, and so we got almost $78 million for the federal side. With all of the state funds that were used, we either will reimburse or return the state funds, or we will seek federal reimbursement to ensure that Maryland is not fiscally harmed from this. And then with that, I'll turn it over to Larry for HR1 implementation. Next slide, please.
Thanks, Webb, and thanks to the chairs for welcoming us today. My name is Larry Handerhan. I'm Assistant Secretary for Programs at the Department of Human Services. I'm going to talk through 3 different types of impacts that the HR1 law has on SNAP. I'm going to talk about eligibility obstacles and restrictions, reduced benefit values, and increased cost to Marylanders. Next slide, please. So as Webb mentioned, there was a lot of, shall we say, drama around the November allocation for SNAP benefits. It put SNAP in the news, but one thing it didn't do is to prevent the HR1 changes from taking effect on November 1st, 2025. So as of last month, you can see on the slide that there are 3 things that have changed. The first is that there are expanded work requirements for a population we refer to as ABODs, which I'll talk about more in depth. Starting November 1st, most refugees and people granted asylum will no longer be eligible for SNAP unless they also have a green card or known as a lawful permanent resident. And households without an elderly and disabled member no longer automatically receive something called the Standard Utility Allowance. Something that's worth noting about the SNAP program, for those who may not be tracking, is that you have to recertify every 6 months, so that there's some variability there. So while this impacts new applicants who present to DHS at a service center, it actually won't impact existing customers until they come in for their redetermination at the 6-month mark. So we're going to understand the impacts of all of these changes month by month over the next 6 months or so. Now I'm going to go down into each of these a little bit more depth, starting with the next slide. So the most broad impact of HR1 on Marylanders is that 80,000 new individuals may be subject to additional red tape through work requirements. So there's a population of SNAP recipients that we call ABODs, which are able-bodied adults without dependents. This is a group of SNAP recipients who do not have to meet the work requirements historically, but they do as of November 1st. There's a couple different categories of people who are impacted. One category is individuals who are 55 to 64. Previously, you would have been exempted from work requirements. You would have been able to receive SNAP every month. Moving forward, you're going to have to demonstrate that you work 20 hours a week, 80 hours a month, or a slight variation of that in order to qualify for more than just 3 months of SNAP. This is a really big change. In addition, those under 65 who have a children in their household, it used to be that if that child was under 18, you were exempt from work requirements. Now you have to have a child that's under 14. So that population of parents who have kids 15, 16, 17 are going to be impacted. In addition, there were different categories of SNAP recipients. There are different beneficiaries, neighbors who were exempt because of their status as a veteran, because they were experiencing homelessness, because they were a former foster youth. Those populations will now all be subject to work requirements moving forward. Next slide. In addition, the HR1 law removes eligibility for SNAP from refugees and people granted asylum, Cuban and Haitian immigrants, or individuals from Micronesia and Marshall Islands, unless they are lawful permanent residents or what is more easily understandable as green card holders. So this is a group of folks that it's not a work requirement change. It is actually the eligibility, and the groups on the screen here are the only ones that are exempted. There used to be a much broader set of refugees and those asylum seekers who were eligible for SNAP. Webb mentioned earlier that there's a bit of a question around recent FNS guidance as to what we call the 5-year bar. So right now, we received guidance on the day before these changes took effect that says that even if you do have your green card, you're a lawful permanent resident, you must be in that status for 5 years before you're eligible for SNAP. And we have joined a multi-state lawsuit because we do not believe that that is consistent with other federal law. We don't have any update on that now, but are committed to continuing to keep you in the loop about where that lands. Next slide. The last thing that's in place as of right now is regarding what I mentioned earlier, the standard utility allowance. This is the SUA. Historically, if you received utility assistance, you were eligible for additional SNAP benefits because you had that kind of support. Moving forward, you're only in that category if you have an elderly member or disabled member of your household. You still may qualify for the SUA, but you will have to jump through additional hoops to prove that. And then other people may end up getting less money than they have historically from SNAP because of the utility assistance changes in the law. Next slide. All right, so those are the impacts that are in place today. You're going to hear from our Medicaid colleagues soon about some of the changes they have that are customer facing, like what I just shared. But there are some very serious impacts to the state fiscal situation because of HR 1. As Webb mentioned, historically, this program has been split 50-50 when it comes to administrative costs. This is the cost of running the program. The state pays half, the federal government pays half. That will increase to the state paying 75% beginning the second quarter of state fiscal year 27. So because the state fiscal year and the federal fiscal year are not quite aligned, that means in fiscal year 27 for Maryland, that's an additional $43 million that we need just to run the program as is. And moving forward, it will be 57.5 million annually just to do the same work that we've been doing to administer the program here in Maryland. This does not include the money that we may need to adapt to all the changes that I talked about a moment ago. Next slide. Also, a very, very large concern to Maryland and all states is that SNAP had historically been 100% paid when it comes to the actual benefit that goes to customers. Moving forward, that is going to be tied to the payment error rate of a state's program. And based on the error rate, you might have to pay up to 15% of the actual SNAP allocation per state. In Maryland, that could be $240 million starting October 1, 2027. I'm going to show the thresholds in a moment, but our current payment error rate, which is, driven by overpayments, underpayments, how we administer the program, every state has an error rate. Maryland is at 13.64 for state fiscal year 24. Based on what that number comes down to for 25 and 26, we'll determine what percentage of the actual benefit itself Maryland might be responsible for. In the next slide, you can see where those ranges are. So this was going to be a focus of ours moving forward, as you can imagine. Next slide. Overall, there's a lot of variability in what I just shared based on the payment error rate, but we are looking at very significant increases to hopefully the general fund to cover the SNAP program moving forward. Next slide. I want to briefly talk about DHS's approach. We are committed to minimize harm. We think the best ways to do that are to preserve access, be human-centered, build practical solutions, and work in partnership with the General Assembly, with our agency peers, and with the community partners across the state. So I'm going to talk a little bit more about what that looks like in the next slide. So we have already, I just joined Maryland DHS in September, but one thing that set us up for success that I was so pleased to learn when I came here was the state's efforts to roll out the One application this summer, which is streamlined benefit access for benefits here in Maryland. This is going to help us tremendously engage with our customers and adapt to the changes of HR 1. In addition, we've already expanded the SNAP employment and training partner network from 30 organizations to 48 organizations. So that will help people who are looking for work opportunities connect to them more easily in their location. We have built a new ABOD screening tool to easily identify individuals who may not have to meet the work requirements. So when they come and seek to recertify their SNAP, we can say, actually, you're not subject to the new requirements because of what we've learned through the screening. We also have a central webpage that we are keeping updated with information that we think everyone can use, how this impacts individual customers. It's also good for our community partners to walk through and understand. We're also working in close partnership with our colleagues. I'll just spend a really quick second going over what's on the slide here. We are working regularly with MDH, the Maryland Department of Health, to make sure that the changes we're adapting for SNAP are aligned with the policy changes that are coming in Medicaid. While the law is not apples for apples between the two programs, there's a lot of overlap. And so we want to make sure that if we're supporting clients on the SNAP side, that work accrues to our partners, and we're not asking people to submit the same information twice, for example, if they don't have to. We're also leveraging existing data sources that we have, like, for example, with MHCC, to make sure we can determine as many people as possible as exempt so that they don't have to meet the work requirements, as long as that's consistent with federal law. The Maryland Department of Labor is a key partner here to really expand the employment and trading pipeline, not just for SNAP B&T, but for all of our programs. There's a lot of people who are going to be newly interested in opportunities, and we all want people to work if they're able. So that's a shared goal that we have across the state. We need to make sure technology keeps up with the changes, so we're appreciative of our partners that do it. We also see a lot of potential in AI, which we can talk about as we develop different tools. And then lastly, we're not just relying on, Maryland partners, but looking outside the state for creative solutions to reduce our payment error rate. We're partnering with a philanthropy and a university to use a data-driven approach to drive down our payment error rate moving forward. Next slide, which is my last one. Our call to action is different for every audience, but we really want to make sure that everyone across Maryland is working with us to be a trusted messenger with their communities so that people know how these impacts might change them and what they need to do to retain benefits. We also want to know if what we're doing isn't working. So if you're hearing from communities that say we need a different level of support than they're getting, we want to know that information so that we can adapt appropriately. And then we're always looking for new partners to make sure that we can get the messaging out, think creatively about solutions, and minimize harm for all Marylanders. That concludes our presentation for today.
Thank you. And I know that we have some questions. I'm going to start with our friends across the street, the Senate. Any questions from the senators? Okay. I don't see any. I do see Delegate Morgan, followed by Rosenberg. Delegate
Madam
Morgan?
Chair. I think I got the audio off. Good to see everyone.
We could hear you now. How are you?
Doing great, doing great. Good to see everyone.
Nice to see you.
Mr. Handerhan, a couple questions on a slide that you had back there. You talked about most refugees not being eligible for SNAP. Those are refugees that have been here less than 5 years, correct? If they're over 5 years, that's part of, they fall into a different category at that point.
That's a great question. That is how we interpret the law, but there is actually so that is not the guidance we have received from FNS. So I don't know. My colleague Heather Zanoni is on the line, I believe, and might be better to answer some nuances there. But yes, the after 5 years, refugees and asylees can receive SNAP. I think there's a question about whether or not upon receiving
previously, before we received guidance on October 31st to be implement on November 1st, if a humanitarian immigrant became a lawful permanent resident, they didn't have to wait for the 5 years. Now they're saying they do have to wait for the 5 years, but that conflicts with existing law. So that is the conflict. Do we follow existing law that was not changed by HR1, or do we follow the guidance from SNAP?
So I think the policy debate that's going to be headed in the months to come during session is whether the state should fill that void in payment. Do you know approximately how many people that is and what's the dollar value of that for those that fall into that category?
We have an unvalidated number. So we're still looking at it. We have an estimate, but it's unvalidated. But happy to get back to you on the validated number once we have it.
You
Thank
can
for
get
asking.
back to both committees when you have the numbers, please.
Happy to do it, Chair.
Thank you.
Thank you, Madam Chair.
You're welcome. Next, I have Delegate Jennifer White-Holland.
Oh, I believe Delegate Rosenberg
Yeah.
was next.
Did I do something
Chair.
wrong? Yeah, I'm
No,
next.
it's just the way I saw it, but you
That's
can go
okay.
ahead, Delegate Rosenberg.
Thank you. Several years ago, under the Clinton administration, there was a welfare reform program passed by the Congress with a work incentive, work requirement. How does this new law differ from what we enacted under Clinton? And a follow-up question is, back then, the Appropriations Committee had jurisdiction for welfare reform. Do we now at HGO have jurisdiction for welfare reform?
So with respect to the Clinton era changes, those were to what is now temporary assistance for needy families and was formerly AFDC assistance for, it's been so long I don't even remember what AFDC meant anymore. So no, it didn't change SNAP back in
Aid to families
1996.
with dependent children.
There you go. Thank you, Delegate. So these are, HR1 is SNAP changes, not TANF changes. That's the difference, two different authorizing statutes.
But where does it go? This probably isn't a question for you. Does
It
it
actually goes to both committees. With
to-
the policy, they're the money, and we work together with Chair Barnes and Delegate Shetty, which is why you see her in our committee. We do a lot of the work together.
Okay, thank you.
My pleasure. I am going to call the way I see it, and I also try to be balanced, okay? So next is going to be Delegate Shalega. You're muted, Delegate Shalega.
She's new to this.
You're going to have to bring some serious cookies to both the Finance Committee and HGO for making us wait. Her grandkids bake great cookies. Go ahead.
Sorry about that. I have this on a new device and I couldn't find the unmute. Thank you all for being here. I do a couple of things that you glossed over was the error rate, and you didn't tell us how you're going to fix that. And secondly, is that where theft goes? Because I know in the BRFA, 30 million was put into theft of SNAP benefits.
Delegate Schlega, the SNAP payment error rate is not fraud. It's a question of bureaucracy. It goes to both overpayments and underpayments, in which case we, as the Maryland State Agency administering SNAP, are the ones that made that mistake. And so we are happy to talk about it in great detail with you. With respect to SNAP, when we came in, Maryland had the second highest SNAP payment error rate in the country, behind only Alaska. In only about 18 months, we've cut that in half, from the federal fiscal year 23 to 25 to 18%. Previously, it was 36%. Currently, the liability assessment is under appeal. And so I believe the hearings are up in February of 2026. Depending on how litigation goes, the penalties may or may not be sustained, or they may be dismissed. If the federal fiscal year 23 penalty is dismissed, then the federal fiscal year 24 penalty is also dismissed. And then it becomes a question about federal fiscal year 25. To answer your specific question about what are we doing, we are approaching it from three levels. The first is really simple. We are hiring people across the state. The Maryland Department of Human Services had one of the higher vacancies of the large agencies in 2023. We've systematically cut that down to single digits. I believe, I think we're into 4 or 5% now for family investment workers. And we've also ensured that there's standardized training. So, I had the privilege, if you will, of attending a training in 2023 for Baltimore County family investment workers. To put it slightly bluntly, it was in a dark room. It was deaf by PowerPoint, and it was not standardized. In the past 18 months, we've taken the time to train our workers, to invest in our workers, and to ensure that they are given the tools that they need to do their jobs. The second is through our colleagues at the Maryland Benefits, through Executive Director Pat McLaughlin and a lot of hard work, we fixed the technology that we've inherited so that it works. The third part then is we've taken the time to manage all of our processes, like my colleague Larry said, to issue a single benefits application, which makes it a heck of a lot easier for someone to apply and to apply with all of the correct documents and all of the documents so that there's less of an issue. For example, one example of a payment error is if someone doesn't complete their application. Prior to this, it would take upwards of 40 minutes to complete a SNAP application. Now we've reduced that to minutes. Previously, our SNAP application was a horror show of you had to use a desktop computer. It didn't auto-save on your phone. It didn't auto-save, period. So if you were kicked out for some reason or had a technology issue, you had to go back and apply, and we had to retype stuff in. So all of these items were systematic process and policy and people fixes that we have implemented over the past 2.5 years. And that has been substantial factors in how we reduced our payment error rate. Sorry to go on a little bit extra.
That's great news, Webster. And obviously, it'd be a huge savings to the state and to taxpayers if you can bring that error rate, down. I think personally that's a good incentive for the states because the state doesn't pay out any of this money. The federal government is expecting us to be good stewards of that money. And you didn't mention the theft. What are you doing about the theft?
So with the theft, the stolen benefits, specifically, that goes to the electronic benefit transfer cards. We went through on October 22nd a new contract that was approved by the Maryland Board of Public Works. That contract starts on July 1st. And so that will be a huge factor in reducing the amount of stolen benefits across in Maryland. The only state so far that's implemented, it's called a chip and tap technology, which I think most of us will have on our credit cards or debit cards, is California. They implemented it earlier this year. And what we did was the new vendor has it as part of their contract requirements. And so we are working with them now to put that on. And we hope to be either the second or third state in the country to bring on this new chip and tap technology. And according to some anecdotal reports, Visa, when they launched it in 2015, it cut fraud by over 70%. We understand from our colleagues in California that in the 6 months that they have implemented, it's also substantially helped there.
Great news. Thank you.
You're welcome. And I know that Peanut White Holland has a question.
Yes, she does. Thank you, Madam Chair, and thank you so much for being here with us and providing us with this information. I wanted to ask about communications, and pardon me if I had to step away to attend to our deputy delegate here. But for those who are impacted in our state due to these changes, what do current and or future communications look like? And how might we as legislators support in outreach and communications efforts moving forward?
I think the simplest just as my colleague Larry put out, it's basically help us rebroadcast information. We are providing as much information as we can by email and text and on through our websites as possible. But it's going to be a long communications campaign, and we ask for every legislator's help to get that information out to your constituents. Where we are required to by federal law, we send out hard copies, but postage is expensive these days. And so we want to minimize the amount of hard copy mail that we send out. That said, we are determined to ensure that when we do send out communications, it's in both English and Spanish. And where possible, if we've identified that there's a large group of customers that are seniors or that are mail only, that we do get them their notices so that they know in time.
Thank you. Delegate Hill, Rosenberg, are you actually asking another question?
No,
All right, Delegate Hill.
my fault.
Thank you, Madam Chair. And Webster, thank you for the work and for the presentation. I just want to follow up on that last question. You didn't mention any television, you didn't mention going on to shows, you didn't mention any social media. Mostly it was, come to our website if you want to find out, or open your email. Are we doing anything in a broader sense? Are we working with any of the local stations to get the word out?
We've been working with local media to get out our public information releases. We also have been putting the same information out on our social media, and all of our local departments have been trying to get information out to the various community fairs, et cetera. That said, we are not able to, right now at least, pay for an expensive media campaign. That's budgets are tight right now. But that said, we're using everything at our disposal to get the communications out.
Delegate Chisholm. Nice to
Thank
see
you,
you.
Madam Chair.
Go ahead.
Yeah, I took it down for a minute, but then Webster spurred my question again. I guess my big question, Webster, is I looked at historically our error rates, and they were low. I mean, they were 6, 3, 2%, 3%. And then in 2022, we jumped from 8% all the way up to 35. You guys, it looks like we've done a good job of bringing that back down, 18 in 2023, and then 13 in 20. So we're going on a good trend. But what caused that huge error rate to jump, and what have we, obviously we've done something to rectify that?
Three factors, Delegate Chisholm. The first is we had a lot of staff turnover in 2020, 21, 22 due to COVID. And the new staff that were brought on weren't adequately trained. I think that's a simple issue of when you're working from home or in remote, it's harder to train them. What we've done though since 2023 is to say, hey, how do we standardize our training? How do we ensure that we hold all of our employees to the same level of training and accountability? If there are problems, we've empowered our local directors to lift up their hand and say, hey, to raise their hand and say, hey, I got a problem. This is what resources, what help do I need to fix that problem? And then, of course, we've made the policy changes post-COVID to ensure that that things are standardized. We expect that there will probably be a little bit of uncertainty caused by HR1 along with the recent federal shutdown, but we are doing everything we can to keep our error rate at or around the national average, and then to reduce it further.
We're almost through 2025. Do we have an idea where the 2025 error rate's going to land?
I do not, Delegate. And the reason why is the USDA publishes the official payment error rate. They usually release it around the end of June of the year following. So even though the federal fiscal year error rate ended on September 30th of 2025, the USDA only releases it in June. Based on our unofficial amounts, we are relatively close to the national average right now. But again, the Feds, that's their number, and they'll release it in June.
Okay. Thank you, Webster. Thank you, Madam Chair.
Okay, I don't see any other questions, so I have one last one for this panel. Will you be so kind, Webster, and tell me what are the income requirements for these programs? Who are we talking about? And Marcos, can you bring up can you go through this chart, please?
Absolutely. And I'll let my colleague Heather as well speak. But if you guys look at the SNAP columns, it's kind of in the middle or left side of the middle of the screen. It breaks out basically here are the income requirements as of October 1st, 2025. If you're a household of one, the gross monthly income requirements a little bit under $1,700. If you're a family of four, it's a little bit under $3,500. And then the maximum income is $2,700. Madam Chair, happy to answer any specific questions once folks have had a chance to digest this visual.
And this is basically the 1,700 doesn't include that. With that, a person, we will have to pay their rent, right? Any medical bills, any telephone, any gas for the car, right? Correct?
Yes.
Okay. And the other question I have, in Maryland, do we know how many people are on SNAP?
There are about 680,000 Marylanders.
And how many counties are receiving people that are receiving SNAP? Is it fair to say all 24 counties?
Yes, ma'am. All 24 counties, and specifically, there are 270,000 kids out of that 680,000, and about 128,000 people with disabilities, and then about 120,000 seniors.
Okay, thank you. Senator Lamb.
Yeah, thank you, Madam Chair. Just a question for Mr. Yee about the fact that HR 1 had an Alaska giveaway, right? This was negotiated by Senator Murkowski that in some ways, I guess, tried to account for those states that had a higher error rate. I assume that Maryland would be better off trying to fall under the lower threshold error rate than than having like a huge error rate that would put us into the Alaska giveaway, right? And maybe you can clarify whether we would even fall under the Alaska giveaway provision.
And Senator Lamb, that's a great question, and questions that have been asked also by the budget side committees as well. We're working both very closely with the Department of Budget and Management and our legal team to figure out potentially best avenues. Obviously, the Alaska option could be an option. Right now, at least, until we're directed otherwise, we think the best path forward is to just lower our error rate as much as possible for any number of reasons. But let's just go with simply, the more accurate we are, the less Marylanders are harmed.
Thank you. Thank you very much for your presentation, Mr. Yee, and everyone else on your panel. On behalf of the Finance Committee and the House Committee, we want to thank you. I know this is not easy. This is tough because a lot of this, we did not cost the KAC, and it's going to destabilize the whole system: health, housing, behavioral health, food, everything. And I hope we can pray that we can figure it out during session. So thank you very much. We're now going to go on to the second panel. We have Maryland Medicaid and Supplemental Nutrition Assistant Program updates, and we have Perry Briskin, Deputy Secretary, Healthcare Financing and Medicaid Director, Maryland Department of Health. Good afternoon.
Good afternoon, Chair. Thank you so much for convening
Thank you for being with us.
Thank you. And thank you, everyone. It's nice to see so many familiar faces and just very good to be with you all on this important topic. For those I haven't met, my name is Perry Briskin. I stepped into the Medicaid Director role about 4 months ago. And today we'll be sharing, following Webb and Larry, an update on the Medicaid side of our OBA implementation. Next slide, please. So overall, when you look at all of the provisions related to Medicaid in the One Big Beautiful Bill Act, we are looking at potentially $2.7 billion in annual federal funding lost to Maryland. Now, the provisions under OBA are being implemented over many years through 2030. And so this is gradually, but just to give you an impact overall of what kind of financial loss we're looking at. Next slide. What we are focused on today are the eligibility provisions that are in OBA. And these are, I think, what many of you have heard about. This is what we have put out publicly. I think this is what we have briefed many of you on over the last few months. Number one is changes to immigrant eligibility. So starting October 1st, very similar to SNAP, refugees, asylees, immigrants granted parole for at least 1 year, and certain victims of abuse and trafficking will no longer be eligible for Medicaid. That really restricts it to legal permanent residents or people with a green card already. It is important to note that pregnant women and children are not impacted by this provision specifically. And we are still trying to make better estimates here, but we believe as many as 60,000 individuals could lose benefits in Maryland due to this change. That then following up is the next requirement, and this, of course, has been getting rightfully a lot of attention. These are the work requirements, also called community engagement requirements. Starting January 1st, 2027, adults ages 19 through 64 will need to show that they are either working at least 80 hours a month or have a certain income above $500 a month. And so this impacts about 320,000 adults in this coverage group, and up to 115,000 could lose coverage as a result, not because they are not eligible, but just due to churn in getting through the system with these new reporting requirements. Next slide, please. Also starting January 1st is the same group of adults, the same group of non-disabled adults ages 18 to 64 will have to go through redeterminations for Medicaid instead of every 12 months annually to every 6 months. So this is impacting this 320,000 adults eligible. And we expect, while this doesn't require as much implementation work, it is going to be one of the places where we are going to see the most churn. We know that when people have to redetermine their coverage, that they often fall out of the system. We are also starting January 1st, 2027, shortened what we call retroactive coverage opportunities. So retroactive coverage used to be 3 months for everyone, and then depending on your age and what group you fall into, it may just be 1 or 2 months. Next slide. These are other OBA provisions that are related to Medicaid that were in the bill. They are not the focus of today's presentation. Some of them relate to financing, provider taxes, state-directed payments, budget neutrality. Planned Parenthood is on here. I also want to flag the last bullet, erroneous excess payments. Similar to SNAP, Maryland Medicaid also has a payment error rate that is determined by the federal government through various federal audits. Historically, Medicaid programs have been put on corrective action plans to correct their erroneous payments. But what is in OBA effective October 2029 is that states will be more financially penalized for excess payments. Maryland's Medicaid error payment historically has been quite low, close to 3%. And the OBA provision says anything above 3%, we would get penalized for. The tricky thing with these erroneous payments is that the more changes that are made to the eligibility system, the more likely we will have erroneous payments. And so we are just yet another reason to make sure that we are implementing this correctly and effectively is to manage our erroneous payment rate. I will say also similar to SNAP, it's a bit of a misnomer to call it erroneous payments. They aren't payments that are made to people or for individuals who are not eligible for Medicaid, it's most often administrative errors, such as a doctor didn't sign the signature line on page 3. They are really more administrative errors than anything. And so, but it is something that we want to be mindful of because we don't want Maryland to come down with a huge, compliance bill because we lost sight of that payment rate. Next slide. Delegate Morgan, I see your hand is raised. I'm happy to take the question now or wait till the end. Nope, wait until the end.
Please wait.
Okay, thank you. So we are implementing all of these eligibility changes, the work requirements, more frequent eligibility checks, immigration eligibility changes. We have different work streams that we're working across. Maryland Department of Health, also on the call today, Maryland Health Benefit Exchange, MDH and MHBE work hand in glove. We have Executive Director Michelle Eberly on this call. And all of these individuals, these 320,000 non-disabled adults where the work requirements will have the most impact, those individuals all go through the Maryland Health Benefit Exchange to apply for Medicaid coverage and to renew their Medicaid coverage. So we cannot do this without MHBE, and they've been wonderful partners to us, as have Maryland Benefits. We have Pat McLaughlin on the line from Maryland Benefits, who also is in partnership implementing these changes. So our objective is to protect health coverage for eligible Marylanders consistent with federal law and guidance. Next slide. Michelle, may I turn over to you here to share a little bit more about MHBE and all that you all do?
Sure, I can be very brief because I think everyone is well versed. So good afternoon, committees. So obviously, Maryland Health Benefit Exchange is a state-based marketplace, and we operate Maryland Health Connection and run all of the Magi Medicaid population through there. I'll just echo what Perry has said, that this has really been a collaborative effort with all of the agencies represented here since we've started this work, and really looking at ways that we can be efficient and effective as we roll out these changes that none of us asked for and that we know are going to really be harmful for the people we serve. So I'll just stop there, Perry, and hand it right back to you.
Thank you, Michelle. Next slide. This is to give a high-level overview of all of the different agencies that are working on different parts of the implementation. APD stands for Advanced Planning Documents. That is really tied to enhanced funding that the state gets from the federal government for any work done as it relates to technology or IT. But we, as you can see, this is an all hands on deck, all government effort, also working very closely with our DHS colleagues who just presented. Next slide. I had just mentioned advanced planning documents. We are submitting to CMS 5 OBA-related APDs. This is really important because this assures the state that we are going to get enhanced match, which for advanced planning documents and work related to IT systems, that is a 90-10 match. 90% of the funding comes from the federal government. So it's really important that we maximize this. And often APDs have a lead time of review. So we are trying to move as quickly as possible to make sure we have that enhanced funding and to take the burden off the state. Next slide. This is our data and systems timeline. I won't go into this too much, but we are working very hard to do as much planning this year as we can, as much implementation and system design next year. Next slide. I want to call out August 2026 to begin internal testing of work requirement systems. These systems will live at MHBE, and they are responsible in partnership with MDH for building a lot of these new systems. Typically, as you know, building new systems in government can take a very long time. To begin testing a brand new system, August 2026 is very, very soon. So we are moving as quickly as possible in order to be compliant with the January 1st, 2027 launch. Next slide. We are doing everything we can to leverage existing data across Maryland government to both verify work requirements and work requirement exemptions. So you can see some of the partners we have listed here. Chair, I'm moving a little bit fast just given the time. Would you like me to pause here and start taking questions, or should I just keep going through this? Okay, we're moving. Next slide, please. We are doing everything we can to leverage AI. And so MHB already does a number of their system work with AI, but we want to expand this. Again, we want to use this as an opportunity, if we can, to strengthen our systems, make them even easier for our members to use, make as many things automated as possible so people don't have to submit paperwork or don't have to follow up with additional information. And AI is a key piece of that. Next slide. We have a comprehensive communications approach here. I will say, in addition to this, we are working closely with our managed care organizations on a campaign to support getting the word out about these upcoming changes. Very similar to Unwinding, if you recall the check-in campaign, it is going to be the same sort of model, where we partner with a communications firm and then push that communication materials out under the MHBE recognizable brand for our members, which is where they know to go for health coverage. Next slide. This is a little bit about the communications timeline. I think one thing to flag is that notices to individuals will have to go out by the end of August. So that is a federal requirement. So we're going to actually have to do formal notification to everyone impacted by then. But I also want to emphasize that communication cannot just go out to the individuals directly impacted by these changes. They also need to go out to other members, so we prevent as much as we can a chilling effect, so people know that Medicaid is still here for them, so people know that they're still eligible. That's especially our members with disabilities, our pregnant women, our children. We want to make sure that people who are eligible stay eligible and don't, assume by reading the headlines that for whatever reason they shouldn't renew their Medicaid coverage. Next slide. I had mentioned this before. We are working with MCOs on a campaign. We have a new MDH webpage that I believe you all already have, but we will re-up. We are also working on what we're calling an ACA deep dive, where we are looking to get more information about who this population is, where they're located, what is their current healthcare spend. And we are going to be releasing a deck shortly, but also having it up on a live dashboard in partnership with Hilltop at the University of Maryland, which is our data partner. And then we are holding, series of stakeholder roundtables. Larry Handerhan and I joke we are on a roadshow, talking to as many people as we can, talking to as many stakeholders as we can, using our existing Medicaid groups, the MAC, the BAC, to just get the word out and continue to share information about what's coming. Next slide. This is a sneak peek of the type of information that's going to be in the ACA deep dive deck. We're trying to get a baseline of, okay, of our population, how many are already working, how many are already in school, how many people would we expect to be eligible still for Medicaid and meet the work requirements with what they're already doing. So we are still refining these projections, but just wanted to give you a sneak peek of what we'll be putting out there. Next slide. We will also be doing enrollees per county. We will also be looking at making sure they're also, I think, by state district. So you can find what is in your district and see what how those breakdowns are, but by age, by race, by sex. So this is just going to hopefully inform people to know, okay, where are they located? And it's probably areas you would expect. You see Baltimore City will be Baltimore City, Prince George's, places where we know our members are and where they will need the most support. Next slide. Again, sort of putting this into context of the changes that are coming. Next slide. Staffing, we are working internally and in close partnership with our governor's office at the moment to determine what level of staffing we will need to implement all of these changes. Part of that is to develop new trainings, new policies, new processes, and also working in close partnership with our local health departments, who also have eligibility workers at the local county level. MHBE has also made a request for additional staff on their end. And so these new requirements do require additional resources that we will likely be asking for in some capacity. Next slide. This is a little bit more about the training timeline. Next slide. Next slide. This is a little more information about the work requirements, what is in the statute. I will caveat with all of this, CMS has yet to put out additional guidance. So there are a lot of outstanding questions of how this will work, timing, attestation, documentation, but we are implementing it with our best guesses and hoping that we won't have to make too many big 180 shifts once CMS guidance comes out. Next slide. These are some of the exemptions that is in statute for the work requirements, but it's a question of how do people attest? Again, back to that error rate, we want to make sure we're collecting and documenting the right type of paperwork. So if CMS does come up in audit, we can share how we are determining whether someone is eligible for an exemption. Next slide. Absent CMS guidance, we are making some core assumptions. And so far, as CMS guidance trickles out, some of these core assumptions will be proven right, some will be proven wrong, and we will just try and be as nimble as possible. Next slide. We also want to take advantage of any flexibilities or ways to maximize the work requirement exemptions. So again, still waiting CMS guidance. Next slide. These are some of the policy decisions the state will be able to make. The statute is fairly prescriptive, so there isn't a ton of flexibility yet over what states can decide to do. And then that is partially some of what we're asking or waiting CMS to put guidance out, is how much flexibility they're going to give to states in this implementation. Next slide. When we talk about medical frailty, these are some of the categories of conditions that we think about. So if you are in the adult ACA group and you are subject to work requirements, these are some of the medical conditions that could make you exempt from having to report work requirements. It is important to note that while you may be exempt from having to comply with the work requirements, you will not be exempt from having to go through renewals and redeterminations every 6 months. So there's still that, but at least for the work requirement piece, you would be exempt from having to comply with that. Next slide. And I'm going to pause here because I think these were older slides that we had on SNAP, but happy to take any questions, and thank you for your time and your support today.
Okay, I see Delegate Shalega first.
All right, I got my unmute going here and on my new device. Thank you. Can you go back to chart 20? Sorry to ask you to do that, but you talked about the expansion population, and I want to make sure I understood that. Is it 90% of the expansion population, or 96% are childless adults? And the expansion means the feds pay 90 and the state pays 10. And this was the Obama expansion or the COVID expansion?
The adult group we refer to as the Affordable Care Act expansion that expanded Medicaid to non-disabled adults 18 to 64. And so we So it's 96% are childless, 4% are parent caretakers. And these are individuals that have had coverage in Medicaid as of 2012.
So this is the Obamacare expansion, and the feds are paying 90% of this, and
Correct.
Okay, and it's almost 500,000 childless adults are now getting Medicaid.
So that number, and I need to check because these are early slides. Alyssa Brown, I believe that number is closer to 325,000. I'm not sure where the 495,000 comes from.
That's correct, Perry. This is just a demographic snapshot from calendar year 24. So you're correct that enrollment is a bit high here in terms of the demographics and enrollment because we were still in the public health emergency unwinding. And Perry, you're right. The number right now is closer to 300,000.
All right, that's clearly better than 400, almost 500,000 childless adults. I guess that's probably why the federal government is looking for every 6-month requalification and a work requirement, which should help people everywhere. So, thank you very much.
Yes, I believe that is the way they found the savings that they did is because this group was at a 90-10 match and has been since 2012.
Thank you. And Perry, just to clarify this, under the expansion, an individual has to live within 138% of the federally, the poverty guidelines, and that is less than $22,000 a year, correct?
That is correct. We have, it depends on your household size, but yes, it's up to 138%. So these are very low income. This is not, we are not talking about marketplace, but yes, very low income.
Okay. Vice Chair Collison?
Oh, thank you, Madam Chair. And with your indulgence, I have two questions that I think are both pretty fast. One is, what is the overlap of the 320,000 people between SNAP and Medicaid? Because they're going to be subject, both these groups are going to be subject to similar kinds of processes. And I think we need to be looking at how we can streamline them so that maybe they only have to do one form every 6 months as opposed to 2 forms every 6 months. That's one question. The other question is, so all of these new tasks that we are going to have to administer as a state, you know, and Perry, you alluded to this, are going to require more staff. So should we prepare ourselves for requests for additional PINs as you move forward with the implementation of HR 1?
Thank you, Vice Chair Collison. Nice to see you. So individuals, I want to make it clear. So we work very closely with our DHS partners and make sure that data is shared. So individuals enrolled in SNAP that meet the work requirements for SNAP will be eligible for Medicaid. In answer to your question, there is a lot of overlap. This is the same population. We have been talking with our DHS colleagues about putting out better communications and public materials to better articulate that overlap, but it is the same population. Medicaid and SNAP have very similar eligibility thresholds, although the applications are a little bit different. So people still have to often go through separate application processes, but we try and use each other's data to verify and make that easier. But we can follow up with you to better articulate that. We are currently working with our governor's office on what this implementation would cost, what we think we need to implement it effectively, and that will come out in the normal process.
And we think that's going to be that cost. A lot of that cost may be in staffing, you know, bringing up.
So I will say so MHBE is coming with their own budget. We are coming with our own budget. Our budget may be more staffing, but MHBE's budget may be more IT system updates because they hold the IT work. So it depends on where it's coming from. I will say what we keep talking about is we would rather invest minimally upfront in doing this well than having to fight the fire and blow our budget in a year and a half when the eligibility system fails and CMS comes knocking and say you didn't comply with what we asked for. So we are really trying to urge to pay for the sprinklers rather to just pay when the house is burning down.
Okay. All right. Thank you. And thank you, Madam Chair.
You're welcome. Delegate Rosenberg, followed by Morgan, then Hill.
Thank you, Madam Chair. Excuse me. You mentioned that there was a prohibition on funding for Planned Parenthood. How does that differ from the current limitation? What is allowed in terms of funding for Planned Parenthood under the existing law and therefore would not be allowed under this new law?
So prior to OBA being passed, we were Planned Parenthood was permitted and Maryland Medicaid was permitted to reimburse Planned Parenthood for most healthcare services. The exception to that was we could not use federal funds for abortions that were not related to the life of the mother at risk or incest or I believe, I want to say a Hyde Amendment, rape and assault. What changed under OBA is that $0, whether state or federal, could flow through the Medicaid program to Planned Parenthood for any healthcare services, whether it was for birth control, whether it was for a mammogram. So that new restriction, it's a year, so it's through July 4th of 2026. So currently no funding in the Medicaid program is going to Planned Parenthood. Now I will flag, and I have Alyssa Brown here with me, who is our director, one of our directors at Maryland Medicaid. It is important to note that Maryland has paid for abortions with state-only dollars. So we did not use federal funds, but we're using state-only dollars for that, and we're using that money to support services, those services at Planned Parenthood. But right now it's zero. It put the stop to all. So we are not accepting any claims from Planned Parenthood at this moment.
But the state could, if it fully funded it with state money, pay a portion of those. Not even with its own money?
So sorry.
They don't have that power.
They do, correct, but it can't flow through the
does.
Medicaid system. So they will argue. So we are talking with our public health colleagues to sort of find a different way to get Planned Parenthood funding. But what the federal government is starting to do on the Planned Parenthood side, but also on healthcare for non-citizens, is saying you cannot use your Medicaid infrastructure to fund these things because that's infrastructure that was paid for and is paid for with federal dollars. So as a way to protect the state, and we've seen this in other states as well, nothing flows through Medicaid because we don't want the federal government coming back and saying, well, you use the MMIS system, the information system that we paid for to pay Planned Parenthood.
Thank you.
Okay. Delegate Morgan.
Thank you, Madam Chair. Ms. Breskin, that was a very good testimony, good presentation, very professional. Could you put back, I believe it was like slide 1 or slide 2, started off with the asylum seekers, I believe. The 60,000 and the 115,000 people that are estimated to
yes,
no longer be put on Medicaid. I just want to make sure we understand that.
Yes.
Okay, so the 60,000 is much like the same question I asked under the SNAP presentation. This 60,000 is currently lawfully present non-citizens that are not seeking, and they're currently covered, correct? And this would be a reduction.
Correct. So this and the 60,000, these are the refugees, the asylees, the immigrants granted parole for at least 1 year. These are the individuals who are currently in the country. And so federal dollars outside of what we call emergency Medicaid do not pay for undocumented individuals. So we have Healthy Babies, which it does fund a little bit our Healthy Babies program, but by and large, this 60,000 are individuals who are currently in these other immigrant categories that as of October 1st, these immigrant categories will no longer be eligible. And it really boils down to just using Medicaid dollars to cover lawfully permanent residents or otherwise people with a green card who have met the 5-year bar.
So you mentioned the Healthy Babies program for undocumented people, and that's in your note right there. Pregnant women and children are not impacted. Yes. I believe that's about $100 million program for the state that's still being covered and reimbursed federally. Now, at the bottom of your chart, it says 115,000 could lose coverage. Now, that's the 115,000 is out of the 320,000 adult coverage, right? Correct? And you're saying the assumption is that they could lose coverage because they are refusing to comply with the work requirements, or they're having problems re-enrolling every 6 months.
Correct.
Correct. Those are the two things.
Yes. So we're saying total, we say between the immigrant eligibility changes and the work requirements and the more frequent eligibility checks, a total of 175,000 Marylanders could lose coverage.
So of that 100, interesting thing. So there's about 1.5 million Marylanders currently on Medicaid, I believe. By your
Closer to 1.4 total, yes.
Okay, so if you take off the 175, that's still more people on Medicaid than it was pre-pandemic numbers, correct?
I would have to check my pre-pandemic numbers, but it's I think we're close to pre-pandemic right now. I think we were 1.3 to 1.4 pre-pandemic.
Okay.
We are.
Last final question, really quick. If the state chooses to backfill these, Medicaid people, I guess, that people are currently on Medicaid, they're losing coverage with like a Medicare for all type situation, it's still about $10,000 per recipient is the benefit that it averages out per Medicaid, correct?
I would have to get back to you on that, delegate. But you're saying what would be the cost if the state assumed fully for state dollars to cover these individuals losing coverage?
Yes.
It would be a lot. It would be in the
because at $10,000 a person, which I always thought the average, and that's what we used before, at 175,000 people, that's 1.7 billion.
We can take that back, but I don't think you're far off.
Thank you. I appreciate it. And again, very, very good testimony. Thank you, Madam Chair.
You're welcome. And if you can confirm those numbers, okay? So just before I go on to the next person, the people that end up on Medicaid, sometimes they lose their jobs, right?
Correct.
Right? And during the COVID, many people lost their jobs, right? And
Correct.
that's why the numbers went up. And now there's so many people that have lost their job at the federal level, correct?
Correct.
In fact, Maryland is the #1 state that has been highly impacted by a lot of the federal decisions, correct?
Correct.
Delegate Hill, followed by Bagnall.
Thank you, Madam Chair, and thank you, Ms. Briskin, for Deputy Secretary. So I guess what I would like you to answer for me, because this is a dynamic system. We're going to comply with the new federal guidelines. We already know there was a significant benefits cliff that people fall out when they start to do a little bit better. The legs get knocked out from underneath them. We're expecting at the very least that people who are getting Medicare, primary care through Planned Parenthood are suddenly, if they're Medicaid recipients, they're suddenly going to be without that care. So if we're projecting, as the vice chair talked about, what we have to be prepared for, she talked about pins in the department. Where are you seeing the squeeze coming? Are we going to have more overcrowding in our clinics and our ERs? Do we need to find more providers in the next 2 years? Do we need, where do we need to be prepared to absorb all these people who won't stop getting sick, because not having coverage doesn't stop you from getting sick? What do you think we need to be looking to prepare to do?
Thank you for that question. And it's something that we think about and talk about a lot. So it is effectively increasing the state's uninsured rate. So where do uninsured people turn to when they need coverage? I think we know that they most often turn to the emergency department. So we have our hospitals and we have our great AHEAD model that is continuing to keep our hospital system strong. But that hospital system is going to be much less strong if the EDs are overwhelmed, if hospitals are overwhelmed with the cost burden of uncompensated care. I think we would be preferring to direct these many individuals to federally qualified health centers and other health centers around the state. But those health centers also need additional support to support this uncompensated care. Just because someone's uninsured, we know that doesn't mean they don't need medicine, they don't need healthcare. And they need often that healthcare and those medicines to work. It goes hand in hand. So I think we're talking a lot about that as a department, and I think we need to be thinking probably about that as a state. I would also be remiss if I didn't talk about the pressures our federally qualified health centers are under, especially as it comes to what care they deliver to non-citizens. And so, especially for that 60,000 group of people, we also saw a proposed rule on the public charge that came out right before Thanksgiving that is going to further, I think, exacerbate a chilling effect among our immigrant community members. So where do those people go? And even though the children and the pregnant women stay eligible, they may be afraid to apply for coverage, not because of OBA, but because of other regulation out there. So it is a really challenging problem. And I hope we can continue to talk about it and find some solutions.
Do we have to also, our behavioral health supports, which we're requiring bill, Medicaid, are they now going to run into a problem? So as we're expanding, we can't do that. Do we need to get more official homeless encampments? I mean, are these the kind of things that we need to be spending our state money on because of these changes?
I think that's a discussion we can have. Deputy Secretary Alyssa Lord is not on this call, but our behavioral health care system, similar to FQHCs, they don't refuse people from care if they show up at their door. But what changes is who takes on that cost of care for the uninsured. Most often it's the state. And so those state, we need to talk about how we are spending those state dollars. We need to talk about how we are continuing to try and do preventative care so it doesn't end up in the emergency department. So these are all very good questions that I think fall a little bit outside the scope of just me, but it definitely for the Maryland Department of Health and our partners to continue to discuss.
Thank you.
I thought I saw Delegate Bagnell, but your hand is down, or do you have a question?
I did. I just had two quick questions. One, first of all, thank you, Secretary, for your thorough presentation. And I know you spoke to being flexible and nimble, but given the previous briefing that we had on SNAP and that we got guidance the day before implementation, do we have a sense of when we are going to get the guidance from CMS? And do you feel like you're creating a long enough runway to be nimble if that guidance comes closer to implementation, full implementation?
Thank you, Delegate Bagnell. Nice to see you. That's the million-dollar question. So many of us were at the National Association of Medicaid Directors Conference 2 weeks ago, where CMS did present informally some initial thoughts that they had. We think the guidance is going to be trickling out, so it won't be just one piece of guidance. It will be a series of materials that come out between now through next year. I don't think we really have a choice but to be nimble. I will say Maryland is led by Alyssa Brown here and her team, in partnership with Michelle and Pat and their teams. We are in we are prepared as much as possible. And so we are trying to take our best guesses, attend every work group. We are in constant communication with other state Medicaid agencies to make sure we're not an outlier in terms of implementation. So we are doing everything we can to prepare for it. I will also say the Medicaid team of the federal side has not been hit as hard with layoffs. And so I know that we all know the career staff there are trying to do their best to make this actionable for states. So at this point, similar to everything, over the last 12 months, we have to sort of, to some extent, roll with it and prepare the best we can.
Thank you. And do you have a sense from what has trickled out, if the state law that we passed a couple of years ago that expedited determination between, SNAP and Medicaid, if we'll still be able to utilize that sort of expedited process for determining eligibility?
Yes, we do not expect that to be impacted. And we hope I would like to find additional flexibilities similar to that help to increase that rate of automation that further relieves the burden from our staff, from our members. It is government efficiency. And so that won't be impacted. And I hope to find other ways to do similar initiatives.
Thank you very much. Thank you, Madam Chair.
Thank you. I don't see any other questions. I do have a question for you, a bit more specific. I would like to learn more about the actions that you intend to take to maximize the exemptions allowed under the law. For example, do you intend to broadly interpret the definitions such as medical frailty, right, to include the most Marylanders, including people that experience homelessness?
I may turn it to Alyssa Brown here. I will say what we have heard from CMS is they may be defining that definition for states. We may not be permitted to have as much flexibility as we would like. But Alyssa, may I turn to you? I know you have been working very, very hard on this question.
Thanks so much. I think we are trying to lean into the flexibility to the extent we can. So we've been doing, so far, the guidance CMS has issued really has been focused on relying on existing rulemaking and guidance. The medical frailty definition itself, right, is not specifically defined in law, but there has been guidance around it tied back to the ACA and alternative benefits plans. So we've been doing a review of how other states have interpreted that guidance to try to cast a broad net within those 5 categories that are outlined in the law: the blindness or disability, substance use disorder, disabling mental disorders, physical and intellectual or developmental disability, and then the serious or complex medical conditions. And then layering on top of that, thinking through this from a data perspective, where can we be relying on claims and encounter data in the Medicaid system, and then also potentially partnering, for example, with the CRISP State Health Information Exchange to broaden that net in terms of potential data that's available from commercial payers or others that might be new to Medicaid. And that process, right, is also in partnership with our clinicians and going to be informed by engagement with our managed care organizations as well.
Thank you. I'm going to wrap us up. I want to thank both the Senate committee and HGO committee and everyone that was here. I'm in a public building, so I apologize the noise. I didn't want to miss the meeting, so I didn't get in the car and I came into a building. I want to just thank you for your time today, and the committee members for your time and your effort. Before I finish, after I like the chair of finance to wrap us up, I just want to say that, I'm really worried about the FQHCs. They service 375,000 patients annually in Maryland. 173,000 of them are Medicaid patients. They have 149 service sites across all regions, and they're located in every county in Baltimore City. And I am really worried about the Medicaid losses, and they often they work and operate really on thin margins because they have to take everyone that walks through the door. If that doesn't convince you, I want you to think about Catholic Charities, which is another nonprofit that is the largest nonprofit provider of human services in Maryland. They have programs in 7 counties in Baltimore City. Okay, they have Hartford County, right? They have Baltimore County, Anne Arundel, Frederick, Carroll, Western Maryland. They service over 200,000 people annually, and over 1,300 households are enrolled in SNAP programs and have Medicaid. They served over 500,000 meals this past year, and that's just two, of the nonprofit and the HQC that I am really concerned about. And this is really horrible. It's really depressing. And I hope and pray that we can see better days. Chair Bidel.
Thank you, Madam Chair. Thank you for the meeting and to everyone that presented. And so I want to agree with Chair Penny-Melnick that it is very disheartening what we're about to face. And then when you layer this on with all the changes with the head and the $450 million that we need to try to make our hospitals whole and our Medicare Advantage plan that's losing 100,000 people, we really have serious issues facing us this year. And so, Perry, thank you for all your work and, for our secretary, but it's really doom and gloom, and we just are going to have to work together to best we can do for the people of Maryland. So thank you, Chair Penny-Melnick. I appreciate the overview.
Thank you, everyone. And it's really an honor to work with you, Chair Vital. I want to thank staff again and every member of both committees and all the presenters. I hope and pray you have a beautiful rest of the week. And if I don't see you before the holidays, have a blessed one.